In this video, we present tackling challenges and exploring the limits with femtosecond laser cataract surgery. None of the authors have any financial interest in this presentation. We review exploring the limits of femtosecond cataract surgery in a patient with a subluxated traumatic cataract, performing a secondary capsulotomy in an aphakic eye, performing femtosecond cataract surgery in a patient with a corneal scar, a small pupil, and phacomorphic glaucoma. A subluxated traumatic cataract. This was a 32-year-old male who presented with a traumatic cataract and 5 flocars of zonular compromise. The surgical goal in this patient with a subluxated cataract was to create a capsulotomy without zonular stress. The second goal was to center the capsulotomy on the subluxated capsular bag and not the pupil. This was achieved by using the custom capsulotomy setting that allowed us to center the capsulotomy on this decentered capsular bag. Increasing the capsulotomy depth to 1000 microns helped compensate for lens tilt. Intraoperative OCT imaging confirmed an intact anterior and posterior capsule. Lens fragmentation into sextants was performed without softening to minimize the amount of intralenticular cavitation gas, which could increase the amount of subluxation. The femtosecond laser allowed us to perform a complete capsulotomy and fragment the lens in a closed chamber prior to creating corneal incisions, thus minimizing zonular stress. A complete capsulotomy allowed us to achieve stabilization of the capsular bag, proceed with phacoemulsification, and achieve a good visual outcome with a well-centered posterior chamber intraocular lens in this challenging case. Next was a case where we created a secondary capsulotomy in an aphakic eye. This was a 45-year-old male who had suffered penetrating trauma and had undergone a primary repair, followed by a pars plana vitrectomy and lensectomy that had left him aphakic. He also had traumatic aniridia. Our goal was to create a secondary capsulotomy in the remnants of the anterior capsule in order to place a 3-piece intraocular lens in the sulcus and capture the optic. To create a secondary capsulotomy in this aphakic and aniridic eye, several modifications were required on the femtosecond laser. The calipers were adjusted in order to identify the anterior capsule remnants. The position of the posterior capsule and crystalline lens were also simulated with the use of calipers. The pupil position also had to be simulated manually as the patient had suffered traumatic aniridia. After confirming the pupil manually, a 5mm capsulotomy was possible. The capsulotomy energy was maximized at 10 microjoules with 3 passes. There were a few areas where the thick fibrotic anterior capsular remnants were not penetrated by the laser, and the capsulotomy was completed using intraocular scissors and a forceps. The picture on the left shows the preoperative image showing an irregular anterior capsular opening with fused anterior and posterior capsular remnants. By customizing the settings on the femtosecond laser, we were able to achieve a centered and relatively circular 5mm capsulotomy. A 3-piece intraocular lens was then gently inserted into the sulcus and the optic was captured, and good capsule overlap was confirmed all around the optic. In this patient with hand motion vision following trauma, using the femtosecond laser to create a secondary capsulotomy in his aphakic and aniridic state allowed us to implant an intraocular lens that was well centered and achieved good visual rehabilitation. To summarize the modifications required to create a secondary capsulotomy in an aphakic and aniridic eye, it is important to simulate the presence of the crystalline lens as well as the anterior and posterior capsular remnants, increase the capsulotomy energy settings, and also maintain centration to allow for IOL optic capture. Next, we present a case of a corneal scar and a traumatic white cataract where the femtosecond laser was valuable. This patient had a traumatic intumescent white cataract, a corneal scar, and iridolenticular adhesion precluding good pupil dilation. The scar was also inducing 6 diopters of corneal astigmatism. Intraoperative anterior segment OCT was able to image through the corneal scar and the intumescent white cataract, visualizing the iridocorneal adhesion and confirming an intact anterior and posterior capsule. Calipers were used to compensate for lens tilt due to the iridocorneal adhesion. The pupil position was manually adjusted to ensure that the laser delivery zone was outside the area of the corneal scar. This resulted in a slightly smaller capsulotomy. Intraoperatively, the capsulotomy was confirmed to be complete after staining with trypan blue. Postoperatively, the patient achieved a corrected visual acuity of 20/30 and a well-centered toric intraocular lens with 360 degrees capsule overlap. So to summarize, a corneal scar is not an absolute contraindication for femtosecond cataract surgery as long as the scar is outside the laser delivery zone. An adequate capsulotomy is possible and the anterior and posterior capsule are intact. It is important in such cases to not focus the laser energy through the corneal scar and to manually confirm the anatomy and adjust the laser energy parameters. A small pupil is also a contraindication to femtosecond cataract surgery. However, several measures can be used to achieve adequate mydriasis prior to the femtosecond procedure, including the insertion of a Malyugin ring. It is important in such cases to ensure that the wounds are hydrated or sutured and that there is a homogeneous fill in the anterior chamber comprising of either OVD or balanced salt solution. The anterior capsule anatomy is often distorted due to the Malyugin ring, and increasing the capsulotomy depth to 1000 microns and the energy to 7 to 10 microjoules helps optimize chances for a complete capsulotomy. And lastly, we highlight the challenges faced when using the femtosecond laser in a patient with phacomorphic glaucoma. This was a 70-year-old female with repeated episodes of acute angle closure due to a phacomorphic element. No preoperative dilating drops were used, and intracameral epi-sugarcane was used to achieve preoperative mydriasis, followed by viscoelastic to deepen the anterior chamber prior to the femtosecond procedure. A complete OVD fill was ensured throughout the anterior chamber and the capsulotomy depth and energy were increased. On the femtosecond laser, anterior segment OCT imaging indicated that the patient had gone into reverse pupillary block configuration. There was a posteriorly bowed iris, increased anterior chamber angle, and iridolenticular touch. She also complained of a discomfort in her eye at this point. Due to this distortion of the anterior chamber anatomy, several adjustments were required to confirm the lens boundaries, accurately identify the pupil landmarks, and the capsulotomy was custom centered. The patient was quickly moved to the operating table where removal of viscoelastic enabled release of the reverse pupillary block configuration, and the remainder of the case was completed uneventfully. Now for her second eye, our goal was to avoid the occurrence of reverse pupillary block. Similar to the first case, we used epi-sugarcane to achieve preoperative mydriasis and were careful to inject sugarcane above and below the iris. We did not use any viscoelastic to deepen the anterior chamber. In this case, she was comfortable during the femtosecond procedure, and anterior segment OCT revealed normal anterior chamber anatomy without reverse pupillary block. The lessons learned from this case are that while viscomydriasis helps to deepen the anterior chamber, an intraoperative reverse pupillary block can occur in eyes predisposed to this condition, including those with weak zonules. This can be recognized by the appearance of the iris and anterior chamber on anterior segment OCT. Evacuation of viscoelastic and tenting up the pupillary margin are effective for releasing this reverse pupillary block configuration. In addition, injecting intracameral epi-sugarcane alone and ensuring injection above and below the iris plane are also effective for achieving mydriasis and deepening the anterior chamber. Following these do's and don'ts helps to achieve a successful staged procedure in a patient with a small pupil or phacomorphic glaucoma undergoing femtosecond cataract surgery. To conclude, this video demonstrates exploring the limits of femtosecond cataract surgery and the customizations required in cases with a subluxated cataract, corneal scar, small pupil, phacomorphic glaucoma, and performing a secondary capsulotomy in an aphakic eye. Thank you for your attention.